Hi guys, today we're going to talk about DID facts versus myths, and my research is through the Recovery Bridge, blackbearrehab.com, psychcentral.com, NAMI, and last the APA. So first question, can you have DID and schizophrenia? That's a misconception. Okay, so I'm going to read. You're going to see me reading. And these are, again, legit articles. The misconception regarding dissociative identity disorder and schizophrenia is largely caused by focusing on a few key parts of symptoms rather than the disorder as a whole. Dissociative identity disorder refers to a condition in which multiple fully formed personality alters coexist and shift within one person. Schizophrenia is a psychotic disorder in which a person experiences extreme delusions and hallucinations. Another important distinction is that people with schizophrenia are less likely to experience dissociative symptoms, such as memory and identity loss. Schizophrenia is also a genetic illness that tends to run in families, and the disorder can result in a gradual decrease in functioning if left untreated. DID is not hereditary, but is most often caused by trauma, past trauma. Now, I also have with that a chart to look at that shows the difference between dissociative identity disorder and schizophrenia, and here's that chart for that. Okay, here's another one. So, can pacifiers heal small alters? Myth. The benefits of sucking on a pacifier to ease anxiety only offers temporary relief. It can help in the moment, but the underlying issue is likely still present. While pacifiers can work this way for adults, professionals still suggest long-term treatment options. Since an adult pacifier is only a temporary fix, finding other solutions should be beneficial. You might consider cognitive behavioral therapy, hence CBT, to find long-term options for easing anxiety. Another option is to identify your triggers and work to overcome them so that you no longer have the urge to use a pacifier. Identifying the triggers can help you deal with the underlying cause of your anxiety. Then you may not feel the need to engage in oral stimulation. This depictation can take 2 to 4 years. Your healthcare provider should be able to refer you to a therapist near you. You can also find a therapist through the American Psychological Association, where they will help you find someone in your area with this issue. If you're unsure what to look for, you can read these tips for finding a good therapist through the APA. Now, here is also a chart of what a pacifier can cause or do to you if you stay on it. So, myth or fact? Are people with DID violent or represent violence? Myth. While the idea of dissociative identity disorder, violent alters, has frequently been the premise of horror movies, it is not supported by what is known about dissociative identity disorder. There is no link between increased criminal activity and dissociative identity disorder. The false belief that people with dissociative identity disorder are violent is dangerous, as it causes unnecessary fear, further stigmatization, and isolating people who have the illness. Okay? Not only are people with dissociative identity disorder no more likely to be violent than other people, but they are also more likely to be victims of violence. Dissociative identity disorder has been traced to childhood trauma. Individuals with this disorder are more likely to be re-traumatized by seeing those that represent or mimic or cosplay violence. Yeah. Next one, is DID, dissociative identity disorder, obvious? Myth. There are multiple contributing factors to this problem of misdiagnoses. First, most patients with the disorder do not present seeking help for the disorder. Instead, a person is more likely to seek treatment for symptoms of the disorder that disrupt their daily functioning, such as mood dysregulation or constant fatigue. In some cases, a person may seek treatment for childhood trauma and be unaware of their dissociative identities. Misdiagnoses can also be due to the difficulty of distinguishing the signs of dissociative identity disorder, especially in outpatient settings. The most obvious symptom, multiple identities, may not be identified unless a personality shift occurs during a therapy session, which could be months to years. Even within the medical community, there are misconceptions about dissociative identity disorder. This misinformation likely inhabits the diagnostic process, as all professionals may not be familiar with the disorder and its specific symptoms or assessments. Further, despite evidence asserting its validity, some providers may still not even believe in the disorder or find it valid. Because the presence of DID isn't always obvious, it can mimic other conditions and can co-occur with other disorders. It often takes time for people to receive the correct diagnosis. According to the Sandron Institute, an organization that deals with traumatic stress, people with DID are in a mental health system for an average of 7 years before the condition can be diagnosed correctly. Myth or fact? Treatment of DID doesn't work and self-diagnosis is valid. Myth. DID is one of the most misunderstood psychiatric disorders. It's important to address the misconceptions with solid research to spread understanding and reduce the stigma around the disorder, especially on media apps. DID can be overlooked due to both this polysystematic profile and patients' tendency to be ashamed and avoidant about revealing their dissociative symptoms and their disorder itself once diagnosed. Some critics claim that DID treatment is harmful. This claim is inconsistent with empirical literature that documents improvements in the symptoms and functioning of DID patients when trauma treatment consistent with the expert consensus guidelines is provided. The DID experts who wrote the guidelines recommend triphasic trauma-focused psychotherapy. I'm going to give you mine. That is the reparenting role and the trauma model theory. In the first stage, clinicians focus on safety issues, symptom stabilization, and establishment of therapeutic alliance. Failure to stabilize the patient or a premature focus on detailed exploration of traumatic memories usually results in deterioration in functioning and diminishing sense of safety. So what they're saying here is they need to stabilize you first, hear your history, and get to know you before they can even assess you and continue with your psychotherapy. In the second stage of treatment, following the ability to regulate, affect, and manage their symptoms, patients begin processing grieving and resolving trauma. Hence the history part in detail, figuring things out with your alters, etc. In the third and final stage of treatment, patients can either integrate or co-consciously exist dissociative self states and become more socially engaged. So basically, and that I'm going to point out again, I've been at this 8 years and I'm already being told I have a lot of co-consciousness going on, but as far as integration, we might be looking at like another year or two. We don't know. It's a long time to work on these things. Early case series and inpatient treatment studies demonstrate that treatment for DID is helpful rather than harmful across a wide range of clinical outcome measures. While the authors noted methodological weaknesses, current treatment studies show improved methodology over the early studies. One of the largest prospective treatment studies is the treatment of patients with dissociative disorders. Top DD study conducted by Brand and colleagues. The Top DD study used a naturalistic design to collect data from 230 DID patients and their treating clinicians. Patient and clinician reports indicated that over 30 months of treatment, patients showed decreases in dissociative, post-traumatic, and depressive symptomology, as well as decreases in hospitalization, self-harm, drug use, and physical pain. Clinicians reported that patients' functioning increased significantly over time, and as did their social, volunteer, and academic involvement. Secondary analysis also demonstrated that patients with a stronger therapeutic alliance, hence trust, evidenced significantly greater decreases in dissociative symptoms, PTSD, and general distress symptoms. So, the conclusion of our video. An enduring interest in DID is apparent in the solid and expanding research base about the disorder. DID is a legitimate and distinct psychiatric disorder that is recognizable worldwide and can be reliably identified in multiple settings by appropriately trained researchers and clinicians. The research shows that DID is a severe trauma-based disorder that generally does respond well to treatment consistent with DID treatment guidelines and assessments. Clinicians who accept facts over myths likely are carefully going to assess for disassociation. Accurate diagnoses are critical for appropriate treatment planning. If DID is not targeted in treatment, it does not appear to resolve itself. The cost of ignorance about DID is high not only for individual patients, but for the whole support system in which they live, their loved ones, health systems, and society. The depiction on apps is inaccurately being displayed. It is known that knowledge must be learned before assessing for DID. All right, that's all I got today. I hope you found this video useful. You're more than welcome to use this in your therapy or to show to your mental health care professional. That's all I got. Love you guys. Bye.